So now we talked about the nose. Let's get back. We're dentists. Let's talk about the teeth. We'll talk about bruxism. Rhythmic grinding. You see the flat, worn down teeth. You see this in the picture? That's rhythmic. You see that? Rhythmic. You see that? Rhythmic. You see that? Rhythmic. You see that? It's clenching. It's tonic. It's phasic. So when we see this, abstractions, you see the abstractions very, very well defined right here, here. You see in little abstractions here, and that's clenching. Clenching is phasic or tonic. Sleep bruxism is a movement disorder of the masticatory system. Now here's the thing. When you start to talk to physicians about movement disorders, they say, oh, so you're putting it in the category of Parkinson's and spasmodic torticollis? Why, yes. That's not my doing. That's the doing of the American Academy of Sleep Medicine. And yes, and the interesting thing, Richard, is because we know Brendan Stack, and does this have anything to do with spasmodic torticollis and Parkinson's? Yes. These guys are treating it every day of the week. Why? Because they're treating trigeminal nerve. Tony Sims, Anthony Sims, Brendan Stack, and they're treating this stuff, and it is a movement disorder, and they're treating it with oral appliances. And so, if you want to write this down, and you look up Anthony Sims on YouTube, you'll see what he's doing. You look up Brendan Stack, what he's doing. Brendan's got about 7 or 8 things on YouTube about treating movement disorders. And wouldn't that be interesting? And if you look at the way Brendan's treating him, you go, is this any different than the way we're treating temporomandibular disorders? And is this any different than the way we're treating sleep disorders? The answer is basically no. No. They just have reached out a little more in that direction. Again, oral and systemic health, we're talking about neurology here. Why aren't we talking about neurology? Do we deal with nerves? Yes, of course we do. And so it's just a matter of seeing what the big picture is around you. And we're already, by being here, you're already out of the box. That's it. We're out of the tooth box. Yes?
So are you saying that they're treating Parkinson's with dental devices?
No. No.
Okay.
Let me tell you what they're saying, because it's a very important key question. They're treating Parkinson-like symptoms, and they're treating torticollis. Torticollis has no definitive laboratory test. So they treat patients with odd movement disorders. Now, I talked to Brendan about this because I've actually edited a few of their papers because they have a lot of trouble getting published, and I seem to have a gift at figuring out how to structure the paper so that the editors will go, oh, this point is well taken. And so what happens is I give them the third degree like you want to give them. And so the thing is, Brendan, how do you know when to treat? That's very simple. If they have a diagnosis, then I don't treat them. And so cervical torticollis, you see this, or Tourette's. You see all these things. There's no laboratory. You can't get a blood test. You can't get a PET scan or a CAT scan and say, oh, you got cervical torticollis. But if you walk in, or not cervical, Tourette's, and you walk in, like my Tourette's impression? But if you walk in like that, that's the diagnosis. The symptoms describe the diagnosis. And so if you don't have anything, say, did you bring a CT with you? Did you bring a MRI with you? Have you ever had it? And yes, I've had it. They couldn't find anything. Boom, he's going to work on them. Okay. But if you say, yeah, I had an MRI and they said I had MS, oh, there's nothing I can do for you. And so what he's really doing is he's treating diseases without diagnoses. If they're bona fide diagnosis, he won't touch it. He doesn't touch Parkinson's, period. But again, Parkinson's is so much like that. There's really very few objective laboratory tests in Parkinson's. And so it's a vague area. Does he get 100% success? No, no. He only talks about the successful cases. And you look at these patients are rolled in a wheelchair and they go tumbling out of his office. I mean, headstands out of his office. These pictures are unbelievable. If you haven't seen them, it's well worth your while to see what the capability of dentists are in these cases. The thing is that the more you do like this and the more you put on YouTube, the more patients you get like this. And pretty soon you're getting cases too many that you shouldn't be doing. You're not getting the weird, you're getting the routine. He won't treat Parkinson's if somebody else can diagnose that it is Parkinson's. And they're getting to where they can find more and more like MRI things, and they say, oh, we know it's Parkinson's. That's not his. It's always unknown diagnosis. But again, Sims is the Tourette specialist. And so, because again, there's no diagnosis. So Tourette's, yes, cervical torticollis, you know, well, they walk in like this. And he treats these. And so it's really, it's worth taking a look. And actually, they're doing an institute program for the Academy of Craniofacial Pain. And so you can go learn how to do this if that interests you. It's really, it is interesting stuff. Okay, so how do we diagnose arrhythmic? So you take electromyographic study, and you have an electromyograph in a metabite, and then a phasic activity is 3 EMG bursts of 0.25 to 2.0 seconds, and that constitutes the diagnosis on an EMG of rhythmic. And then tonic is clenching. So a tonic burst, a clench, lasts over 2.0 seconds, and you'll see these in repeated clench, clench, clench. And they can last over 2 seconds, can be a 20-second clench. But that's how they do it. And so, I forgot her name, the dentist from Canada, what's her name, the one that does bruxism? No. Yvonne Habrowski, HR, HB, Habrowski does these studies, and she's using metabite EMG. You have it in your kit when you get one. And then there's mixed, where you can have both types within a 3-second period. So, yeah, you can have people who grind and clench at the same time. And then 88% of sleep bruxism episodes are either phasic or mixed. So the phasic is more common. Okay, and so you look at the EMG, you're getting a picture. The phasic is more intermittent. The tonic is a clench. And what you're looking at here is grind, 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 and then you're looking at clench. You're looking at clench, grind, 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 grind. So you get a picture of mixed, and you get a picture of tonic, and you get a picture of phasic. Okay, so we have 2 types of sleep bruxism. Primary, absence of a medical or psychiatric cause. Secondary, associated with a medical condition. So if you have bruxism associated with depression, Parkinson's, or schizophrenia, that's secondary. And then secondary is iatrogenic. So that means iatrogenic, if you put a filling in that's too high and it keeps grinding on it, that's iatrogenic bruxism. And then it's also been written up as a side effect of certain drugs, so that people who take, you have to ask the medical history. If they have a history of Zoloft, Paxil, or Prozac, that could be the cause of the grinding, the bruxism. Primary bruxism, there's absence of a medical or psychiatric cause. It's idiopathic. They don't really know what causes it at this point. And a majority of all sleep bruxism patients with no associated medical or psychiatric conditions, So here's the thing. Sleep bruxism occurs mainly in the lighter sleep stages, stages 1 and 2. Sleep bruxism occurs at a mean frequency of 5.4 to 5.8 episodes per hour of sleep. So it's not constant. It's not like it's going on all night. And sleep bruxism rarely occurs in REM sleep because you have this muscle atonia. So the idea that you'd be clenching in REM sleep is inconsistent with a muscle atonia where you're actually in paralysis. And sleep bruxism has little effect on sleep architecture, according to Redding and Detmer. Prevalence, 6 to 20% of the adult population. It decreases in prevalence with advancing age, and the lowest prevalence is in the population over 65 years of age. Clinical diagnosis. Clinical diagnosis, if the patient reports that they're tooth grinding or clenching, that's pretty good evidence. In combination with one or more of the following signs. If if somebody reports hearing tooth grinding noises, or you see the pattern we just showed of abnormal tooth wear, or they have temporomandibular joint-related pain and headaches, so that the muscles are tender, they're getting headaches. That's another associated diagnostic sign. Chewing discomfort. It hurts to chew. And you're going to see this where they used to call this dental compression syndrome. The patient will come in and you'll say 4 root canals in a row on the upper, say the upper teeth still hurt. They must not have done the root canals right. And the root canals are done first maybe on, let's say, the second molar, and the patient comes back and says, no, it still hurts, it's this tooth. You do the root canal on this tooth, and they come in and say, and then they wind up on the last 2 teeth usually at the same time, and the pain is still there. What's going on here? These people aren't crazy. It's dental compression syndrome. They're compressing the periodontal ligament, and they're putting pressure on the bone. And so that's what they used to call it, dental compression syndrome. It's probably the muscles are in fatigue, and it's a very it's a pernicious type of thing because it's self-limiting. Next thing you know, they'll be in and they'll have the lower teeth hurting, and then pretty soon they have, let's say, 8 root canals, and the pain is still there. And at some point, somebody's got to stop and say, wait a minute, let's check for jaw-related pain. And it's not even jaw-related, it's muscle-related. It's a facial pain condition. Okay, so temporomandibular joint, chewing discomfort, hypersensitive teeth, which is another bugaboo. The patient comes in and, it's just so sensitive up here, I can't live. I can't do this, I can't do that. I can't take a cold glass of water. I can't go anywhere near an ice cube. That's the hypersensitive teeth. And the other thing is simply masseter muscle hypertrophy. You touch them on the face, you palpate the muscle, and they're jumping out of the roof. Okay. So PSG criteria, what are the polysomnographic criteria? If you have a metabite more than 4 episodes per hour, more than 6 bursts per episode, and or 25 bursts per hour of sleep. If you have at least 2 episodes with grinding sounds, these 3 criteria, diagnosis was correctly predicted on the basis of these 81.3% of controls and 83% of the Bruxers. That's Gilles Levine. The sleep bruxism grinding sounds at clinical exam are corroborated by grinding noted at PSG. That sign alone has a sensitivity of 78% and specificity of 94%. So these things, they're not very complicated. It's almost like diagnosis by definition. And the characteristics are the characteristics of sleep bruxism patients compared to controls. There's 3 times more EMG bruxism episodes per hour of sleep in the bruxism patients. There's many more sleep bruxism episodes in lighter sleep stages than in REM sleep, and most sleep bruxism episodes occur when the patient sleeps supine. No single mechanism or theory explains the pathophysiology of sleep bruxism, is what the literature says. And again, that's a little changing in that they're now talking about the body's attempt at a lower brain level to dilate pharyngeal muscles. So, there's another thing that they've noted, and you'll see it in the literature, it's called rhythmic masticatory muscle activity. And sleep bruxism does not equate to rhythmic masticatory muscle activity. If I have to summarize to you, my opinion of the literature on that is that when we said that when a child's nursing, they're nibbling. And the nibbling rhythm that a child would do is what we see as rhythmic masticatory muscle activity. It's exactly the same frequency, and it's exactly the same kind of event electromyographically. And so I guess it is that some people have the tendency to nurse in their sleep. Maybe it's some primordial urge. And so that's what happens. There's a lot about this again. Let's talk for a moment, just because my mind thought of it. Let's talk about palatal rugae. Palatal rugae. What are they for? So pallor rugae have 4 specific nerve endings. Meissner, Merkel, Ruffini, and Piccini end bulbs. Everybody had this on the histology exam when we were in school. Huh? I can't remember back that far, but I remember as soon as I heard it. Yes, I probably got the question wrong. Okay, so we have Meissner, Merkel, Ruffini, and Piccini end bulbs, and the end bulbs are interesting because you have to have, if you see a picture of these, they look like these new spiral light bulbs that you have, the new kind of light bulbs that are fluorescent, but they curl up. Okay, that's what they look like on the picture, histological pictures. And so what are they for? Well, it turns out that the Meissner, Merkel, Ruffini, and Piccini end bulbs have autonomic sensations, autonomic nervous system function. And the autonomic nervous system is to clear the nose, to make the nose better for breathing. 2 of them, Meissner and Merkel, are pressure sensitive, and 2 are suction sensitive. So you think about this for a moment. When a kid is nursing, it's push, pull, push, pull. And so, to my sense of that, is that if the tongue is in the roof of the mouth, then we're stimulating those. And can we train the tongue to stay in the roof of the mouth? Yes. And why would we train the tongue to push, pull? Because it's going to help us keep a clear nose at night. Are we going to sleep better with a clear nose? Yes. That's part of the reflex activity we're going to talk about with the Moses. It equates. Okay, so rhythmic masturbatory muscle activity. I meant to save a little time and skip over it. Sleep bruxism may be involved in maintenance of airway patency during sleep. Following microarousals, an increased activity of over 150% is noted in the diaphragm and upper airway dilator muscles. That's evidence that that be the case. And then sleep bruxism may be involved in maintenance of airway patency during sleep because according to Levine, when ventilation resumes following an apnea episode, a coactivation of tongue protruder, the genioglossus, and retruders, the styloglossus and hyoglossus occurs, contributing to prevention of pharyngeal collapse. So even Levine is starting to say that we're related to, sleep bruxism is related to airway dilation.
I have a comment.
Yes.
I'm looking at an article I have right here. It's from this month's California Dental Association Journal.
Yes.
It's entitled Sleep Bruxism and Autonomic Self-Regulating Response by Triggering the Trigeminal Cardiac Reflex.
Yes.
Are you familiar with this?
No.
I mean, it's an hypothesis.
What's
basically that these microarousals cause tachycardia, and the bruxism through this autonomic nervous system results in a lowering of the heartbeat.
This is, well, again, it's the same thing. It's the Lee Osler theme that we're dealing in an area of oral systemic health. That's what I've been saying for 2 days. And we're all putting it together now. Eventually, we're going to have a huge bibliography that's going to say all this. And again, there's a certain common understanding that we share today. So, you know, I could say, remember histology in school, Ruffini, Piccini, end bulbs, and there's a certain dental school thing. There was a certain amount of stuff we took. There's a lot of stuff when we took it in dental school, we go, I'll forget this. And you did forget it the day you got out. But there's a lot of stuff that we learned which established for us a common language so that we all understand each other having this common education. But what we're talking about today and yesterday and tomorrow are off the beaten path. But that doesn't say that in the next 5 to 10 years they're not going to be mainstream. It just takes a while for this stuff to filter into the mainstream, and until it does, the old school is fighting it. There seems to be a certain amount of resistance to to change. And so it was interesting. When I addressed, a couple of weeks ago, I went to address the Western States Board of Regional Dental Examiners. And there was a guy from Southern Cal there that I met, Mulvihill. And so the point is, what I said to them was basically, hey, the stuff that I'm telling you today, you taught us in dental school. You gave us a good basic education. The thing is, what we're trying to do today is we're trying to synthesize that information into something at an advanced level. We're taking a look beyond our normal parameters. So instead of teeth, we're looking at sleep, and we're taking this basic education that you gave us, and we're extrapolating and synthesizing new information. I think that's what's happening. And so they were looking for an argument, really, that they wanted to know, they were arguing almost that, you know, we don't have to teach a lot. We don't have any more room in the curriculum. And I'm saying, hey, you're doing fine with the curriculum you got there. The stuff that I'm telling you I learned in dental school 40-some years ago, and the same thing. But, and so they were very happy with my message. All you got to do is teach the students how to synthesize that information a little better. And so what happens is there's too many of our colleagues who get out of school and are doing nothing but drill, fill, and bill, and they're resistant to this kind of change. And then there's physicians who feel threatened by this kind of change. And so nothing happens fast or easy for us. But this is what's happening. We're building the database. We're building the body of knowledge, which this kind of stuff will be common knowledge in 10 years. So we're pioneers. We're out of the box right now, and we're all comfortable with it. That's why we're here. And we're going someplace because we know things that no one else does that work. We're helping people. We're getting tremendous. The satisfaction you're going to get from this is unparalleled. The satisfaction you're going to get from other fields. You'll say, this is so thrilling. This is so exciting. I want to do more and more of it because it is that way. And that's exciting. That's really what we're here for. And that's where we're going. But it's not mainstream because, look at the whole United States, and Modern advertises the hell out of this course. They send it to thousands and tens of thousands. 15 you guys showed. And that was great. You're a good 15. Thank you. But the fact is that we're still out of the mainstream. Look at the, it's just not happening. And interestingly enough, the ones who, yes, the American Society of Dental Sleep Medicine, American Academy of Dental Sleep Medicine. So at this meeting in Boston, they had 1,200 members. And it wasn't a good enough meeting, or they didn't have enough confidence in the members. There's not one breakout session. They sat all 1,250 in one room, and it sounded like wah, 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 wah. All you hear is this one microphone. You don't know what the hell they're saying, and somebody's up there giving you double-blind controlled studies, evidence-based material, and it applied to this much of the group, and everybody's sitting there, and it's what you learn in the lobby, and it's what you learn at the booths that was so exciting. Right, Fojas? Yes. Yeah, thank you. I know, and you too. This is the point. There's something being missed about that, but everybody sees this. Nobody's helping to put it together like this. And so it's happening. There's a mini residency at Tufts. You got a thing in your book. That's 4 weekends of 3 days. 3 weekends of 3 days. 3 weekends of 3 days. They cut it down. But it's also you got. I've been there. I teach there. It's a wonderful faculty. Okay, that's a good kind of a program. And it's taught by Nosher Mehta and Bob Talley and James Spencer. These guys are terrific. And so there's some things. We're getting there. We're getting there. And the other thing is the recognition is coming because, look at Tufts University is no lightweight. Tufts University is the largest dental school in the country. They have more students in Tufts than any other dental school in the country. They are the largest school in the country. And so the fact is that Tufts is teaching it. And, well, Tufts is in Boston. How far behind, can Harvard and, Boston University be? The point is that, yes, we're getting there, but it still takes a certain avant-garde to challenge and to push. And we're there. We're there. Look at the stuff we're talking about. We're taking this to a level of mouth guards. We're taking this to a level of carbon dioxide end-tidal CO2 testing. We're taking this to a level of tongue reflex training. This is good stuff. And so you go home and you could hopefully teach this, or hopefully tell people about it, and hopefully help people in your practice. Okay. Let's get on. All right, I'm ready for the next lecture here. Okay. So we have the Moses Appliance. And I want to talk to you about it relative to sleep bruxism. Because people repeatedly say to me, Alan, because you have this here, this is a weak point, and because you limit them, you're going to get a real strong bruxer, and they're going to break these wings off. And so, okay, what I don't show here, John, I need a new demo, because what they've done is they've reinforced in here where it occasionally did break, and they've reinforced in here with titanium bars. So, okay, there was something. But I want to tell you something else. See, John and Patrick Tessier, the owner, are so demanding that if they have, you know, a 92 to 95% success rate, that doesn't go. They don't want 8% makeovers. So we get together, they have a meeting, and everybody screams at everybody, and we work on the gains. And so we've been very nice, because John is very, very brilliant, and he helps with the technical stuff, and Patrick's majored in mechanical engineering, and we sit down together, and we reason these things through, and we're making it better. But, okay, that's not the reason, because it still didn't break that much. But why doesn't it break? Because, remember what we said, muscles know how to contract. The shorter that muscle is, the more power. We called them masseter dominant because we saw big masseters in here in, what's the guy's name? I don't know, the actor. Brad Pitt. You see masseter dominant, you see muscles like this, and these muscles can generate, we know, tremendous power. They generate the maximum power in centric occlusion. They generate more power if you sawed off a little of his teeth, because they're shorter. Now they can contract and generate more power. So you don't want your finger in there when he contracts them. But the fact is that muscles generate at their shortest length more power. So when we do this appliance, we're lengthening the muscle. We're putting shims in here, and as we put the shims in here, we're changing the vertical. If you lengthen the muscle, you can't generate the power. So I did a study in 1989, and it's in my CV if you want to find it. And what we did was we measured the power in centric occlusion on masseter and temporalis, and we measured the power in an appliance very similar to this, and we found that we generate something like 50% of the power in masseter and temporalis, opening at like 2 millimeters. We're opening some of these patients 6 millimeters. You don't have the power. So when you want to go like this, you don't have the power. You think it's going to break, but it's not going to break because you don't have the power. If you break it, okay, we have two choices. We can make it non-adjustable and just bulk it up, or you can choose a different appliance. But the fact is it's not happening because we don't tolerate, you know, more than 2% breakage, and then if it's 2%, we blame the technician. We blame the doctor. We don't blame ourselves. But that's what we strive for, and that's what we're working for, and that's why we want your feedback. It's not like we want to make it hard for you. We want to make it better for you. We want you to have that 98% success rate. They're giving you a 2-year warranty on this. They don't want to see this back. And so, but the fact of the matter is that because we increase the vertical and because we bring the mandible forward, yes, we're dilating the airway, but by dilating the airway, we're decreasing the power, so we're not seeing the breakage from bruxism. Yes, sir. Get him a microphone.
I had an experience where one of the patients dropped the appliance by accident, and it actually cracked in one area, and we had to replace it. But I was kind of surprised that it fractured the way it did.
You know, we were too.
No, I sent that to you.
Yeah, no, we were too. And so John was there dropping appliances on the floor and finding out where they break. And they all break in that place, so we reinforced it. That wire on the lingual is not an accident. That's planned, and we don't see the breakage since then. Yeah, we're on it. We're trying our best, absolute best, to make this work. So that's what I want to talk about. Let's go on. So the advantages of sleep bruxism. A, it controls sleep bruxism because you can't grind in it. You can't clench in it. It prevents tooth wear. It reduces the electromyographic power of the clench. It deprograms muscles. You put that in tonight, and you take it out tomorrow morning, and guess what? You'll say, hey, what do you do? You change your whole bite. You'll be edge to edge. It's a muscle deprogrammer. That's the point. It is a muscle deprogrammer. Historically, it started out. I had the apnea, I think I told you, and I wanted to find an appliance. So I thought, well, I went through everything else out there, and I went back to the John Witzig bionator, and I started out with a bionator to neither open nor close the bite. Then I made the suck downs to open this area up so I could get more tongue room in the front. And then, still wasn't working, so I took the wings of the bionator and moved them out of the mouth into the vestibule to create more tongue space, and that's what did it. And then it was non-adjustable. So the point of that is I increased volume of space for the tongue. But it's a muscle deprogrammer. Back to the story. Why was Witzig using it for orthodontics? It's a muscle deprogrammer. So okay, so it advances the mandible. It properly positions the TMJ disc on the condyle. I mean, this is not an accident that we're using this for temporomandibular disorder cases. It increases volume of space for the tongue. It decreases or prevents tooth sensitivity because the tooth sensitivity, the abfraction of the bending of the tooth, we don't generate the power, the teeth don't bend. The sensitivity gets better. It prevents pharyngeal collapse. It relieves muscle tension headache because they don't have the tension. What's the pain in a muscle tension headache? Why does it hurt? It hurts because you've created fatigue in the muscles. What's fatigue? Fatigue is anaerobic metabolism. Anaerobic, too much lactic and pyruvic acid. You have lactic and pyruvic acid. You go throw a baseball or play tennis, your shoulder hurts. The shoulder gets better after a couple of days. Why does the shoulder get better? Because the body washes away the toxic waste products. Okay, so here we have this muscle here, and we never, ever stop grinding. Every day, every night, we're doing it. So we have fatigue. The system breaks down. We can't get rid of the anaerobic metabolites. So what do? We relax the muscle. How do we do that? We deprogram it to a position of low muscle activity. So they wear this thing at night, and the muscle is deprogrammed, and the muscle is relaxed. It's relaxed in the sense that it's not relaxation 1 to 2.5 microvolts. It's lower EMG activity. And then the tissue, the blood can get in there. If you stretch it a little bit, the blood vessels aren't as constricted, you get more blood flow, the thing calms down. And so, okay, we have an appliance here. We can relieve muscle tension headache by stretching the muscle and allowing more blood flow and taking it out, getting rid of the fatigue. That's how it works. That's how the pacivator, that's how the bionator, we call it a pacivator because it's not a pacifier, but it's a bionator to neither open nor close the bite. And so it relieves muscle tension, and it's comfortable. And that's why if you look in the brochure we gave you, what you'll see is that we're saying it's comfortable. The athletes can keep it in. You keep this in all night. It's comfortable. This whole orientation, comfort is important. We want it to stay in all night. We want the mouthpiece to stay in the mouth. It's comfortable. And comfort is a huge a factor of why it's successful. We don't want it on the nightstand in the middle of the night. We don't want it under the bed like the CPAP. It's uncomfortable. Okay, it has been shown that CPAP elimination of obstructive sleep apnea eliminates snoring and mouth breathing. It has not been demonstrated that CPAP treatment of obstructive sleep apnea eliminates or reduces the sleep bruxism. We are saying that for an oral appliance. Conclusions, there's no reason not to use a bruxism appliance in conjunction with CPAP. The Moses is effective against sleep bruxism as well as apnea and snoring.